Thank you, Professor Talwar and Professor Tiwari for the opportunity. I apologize that the keystone is not working on the main screen, but so the inferior part of the screen is cut off, but I think the side screens are. I have no financial disclosures. I thought since you've seen from the front portion to the back portion of the eye, we'll restrict it to two components of OCT that you may not come across so often, but it's so exciting. Uveitis mainly, and then pediatric retina. Since uvea is not my core competence, I've borrowed these slides from my colleagues in Narayan Nethralaya. I'm going to quickly run through them so that you understand how OCT can help us pick the location of the pathology or the severity. Now, cat scratch disease is classically seen with optic disc edema, macular star, and sometimes the fellow eye is normal. What is seen here is the fact that there's subretinal exudation. Just monitoring this can sometimes tell you how well the vision improves. In other cases, in different forms of retinitis, unless you have a lab backing, it's often confusing on where the location of this retinitis is. Inner retina, outer retina, retinochoroid or choroid. And based on where that is, you might actually be able to pick the etiology. So that's where the OCT helps. So this is the chikungunya retinitis. And this whole big lump here is a hyperreflective patch of the retina. Now it's easy, you've understood that this is the inner retina, and then you see the space in the fluid in the outer retina. So one affects the location, the other one affects the vision. This, on the other hand, is a slightly more outer retina appearance. So this is the multiple evanescent white dot syndrome, or MUDS. And you see in FAF and FFA, they have classical appearances. But let's see what happens on OCT. So these are, by definition, focal changes. So they don't happen throughout the ISOS. You see apoptotic bodies and you see vitreous cells. So these are things that you might want to tune yourself into seeing. Then you get an immunocompromised patient, HIV positive, and this is a common condition in them that progresses very rapidly. And here you want to know that this is the inner retinal thickening. And if you can look from the side screens, because you can't see lower here, the outer retina still has edema. So again, this is inner retinitis with outer retinal changes. And this rapidly progresses, and you can look at the change now. Within a few days and sometimes a week, the entire retina is almost moth-eaten. And this is when they usually go into rhegmatogenous retinal detachments and often need surgical intervention. Let me now focus a little bit on pediatric retina, because there's a lot of general ophthalmologists, babies and patients are some set of people whom you can actually run OCTs on and what information we can get. Now, OCT devices have come a long way from the time you had to take the OCT machine into the OR, or actually the flying baby position as was popularized by Oxford. Today to handheld, either you can dismantle your spectralis or you can have a handheld OCT itself. Your patient is extremely cooperative as long as you sort of swaddle him well, and these babies can be fairly easy to image, contrary to the popular belief. So how are these layers different? And you've seen this picture time and again. This would be an adult male. Suffice to say, the outer plexiform layer goes and has a hyperreflective dot at the foveal dip, and the outer retina has usually 1, 2, and 3 lines. Now, let's forget the names. Let's come to see what happens in an infant. So we are all not born with normal OCTs. That's for the first point to take home. The outer plexiform layer has quite a distance to grow before it touches that. So this is called the inner retinal persistence. This is important because if you see a 5 or 6 year old with this kind of persistence, he's bound to have lower vision. And these are some of the amblyopes that may be walking around in society. And here is the ISOS. And you can see that this is straight. You almost don't see that little bit of hillock. And that's because the cones are not tall enough there. And these can either be injury, retinitis, or even dystrophies. But as long as you recognize them to be abnormal. Albinism, fairly common, easy diagnosis to make, but in terms of prognostication to the parents, you want to tell them whether there's foveal hypoplasia or not. Only 25% of albinotics have foveal hypoplasia, and that's easily differentiated on OCT by a flat line, an absence of a dip, and the inner retinal layers almost looking the same. There's no fusion at the ILM. Leber's congenital amaurosis. Now, this would be often a condition called when you see nothing in the eye and the patient sees nothing also. So the retina can look completely normal, but the OCT is very classic. You can see that the neurosensory retina and the choroid are almost of equal thickness. And the reason is there is neurosensory retinal atrophy. And in the oldest cases, you will hardly see any ISOS junction, almost no photoreceptors. And this is the inverse sign because the chorocapillaris looks actually bigger than the others. Rubella, this has been one of our reports where we know that it's seen as salt and pepper retinopathy, always believed to affect only the outer retina and the retinal pigment epithelium, but we showed that you get outer plexiform changes as well, some sort of deposit-like jagged appearance of the outer plexiform. More of an academic interest. This picture is borrowed from Bascom Palmer, and this is a shaken baby syndrome. OCT was the first medico-legal investigation from ophthalmology to be admitted for medico-legal purposes in the US for babies. So this was a shaken baby syndrome, and when you have foveoretinal traction and you have multiple points of separation with foveal disruption, this is regarded as non-accidental trauma. We had shown some time back that you can use OCT to selectively look at neovascularization in aggressive posterior ROP and direct supplement laser exactly on that and make that go away. A curious combination, because I'm going to now show you how you can combine FFA and OCT even in a pediatric case. So this child actually did not come with the diagnosis of tuberous sclerosis. We made it because after we saw what we saw in the eye, we looked along the body and we found these Ashley spots, and then on questioning, the child had seizures. So here's lesion number 1. I hope you can see it, fairly large, easy to diagnose. But then there's a subtler one here, right here. And then the third one in the fellow eye right here. Now, if you don't believe me, you've got to look at these OCTs. So the larger one was very obvious. It had the superficial retina looking fairly undulated. And as Dr. Yadav said before, here's a vitreoretinal traction. So when there's a vitreal interface, retinal interface going on, you see irregularities, and this actually stained on angiogram. But when you have a smooth contoured lesion, like the other two, it doesn't even pick up on angiogram. What does this mean? Obviously, the dye will leak into the vitreous or around the tumor if there is some disturbance over its surface, and that's what we were seeing. So this is how you can actually correlate structure with another structure and then function, and this is the fellow eye lesion, absolutely nothing on angiogram, but picked up on OCT. Some of our findings have been on the subclinical. Dr. Talwar mentioned how sometimes the eye looks normal and yet you pick up pathology. In 30% of retinopathy or prematurity cases who did not require treatment, mind you this is mild disease, we found a cystoid macular edema-like pattern. We classified it as two patterns, pattern A, where there was complete disruption of the foveal center, and pattern B, where there was some preservation of the foveal center. We followed up these babies, and we showed that the highest visual change was in the first 3 months. So all that edema completely resolved by the third corrected month, and from month 3 to month 6, there was a massive improvement of vision in the edema group, and they almost equalized with their other counterparts who were age-matched controls without edema and no ROP at all. So these were positive and negative controls. I just have 2 more slides, and this one's actually to tell you that a lot of amblyopes, especially anisometropic amblyopes, and sometimes with the refractive errors not significantly high enough, can have potentially retinal substructural problems. So here's one. So he's 6'15", and this is both eyes 6/15, not improving with glasses and patching. So what do you see here immediately? You see a broken in ISOS line. The external limiting membrane is again broken. The outer nuclear, which is the black portion here, is so thinned out. So the rest of the inner retina is almost caving in on the outer retina, which means that there is an outer retinal problem. This could be retinitis, this could be dystrophy, and these patients need to be investigated for that rather than continuously taking on patching, which may not help in his case. Again, I'd like you to look at that image, which is not very clear here. This is aggressive posterior ROP that's been undertreated and waiting for this ischemic loop to either vascularize or for you to do a supplement laser just a week later. The destined fovea is somewhere here. This child is just about 33 weeks old. And again, this is our very, very 3-week-old experience in using the OptoView Avanti OCT angio, where we're doing non-invasive angio images along with OCT. And what are we picking? We're picking the neovascularization, which is obviously seen here, which we've seen before, but what we're able to see its extent. This is the superficial retina, this is the deeper retina, this is the outer retina, and this is the choriocapillaris. And of course, you can't use the word blocked fluorescence because there is no dye, but the hypo shadows, the hyporeflectivity is obviously because of the location of the NVE. So we are actually monitoring these patients now, looking at their NVEs and looking at what happens. And you can see from this picture where you see this large complex of NV. After treatment, it's now just few fronds, and obviously we're waiting for them to go away as we do more supplement treatment. And this is called the en-face OCT, and this is where the future of OCT is going, where you're looking at layers as though you're looking at it from top, and with segments at a time, with one reference plane above and one reference plane below. So when you're looking at this is again the en-face of the superficial retina and goes all the way down to the choriocapillary. So in the choriocapillary, your point would be the RPE, and for the superficial retina, it would be the ISOS. So in summary, OCT, as everywhere else and all the other speakers have shown you how useful it is in regular clinical management. Remember that in uveitic and pediatric retinal conditions also, it tells you a lot. In uvea, we saw how it can help us localize the lesion, to treatment chronology, response to treatment, we showed you some, and sometimes if you don't, and in pediatric retina especially, help us understand the disease better and probably correlate what we call structure with function. A lot of these cases are taken from our OCT textbook. It was published 2 years ago with Elsevier, and that's the title. Thank you very much.